Today, I would like to introduce to you Dr. Margie Balfour. She is a psychiatrist and national leader in quality improvement and behavioral health crisis services. She is the Chief of Quality and Clinical Innovation at Connections Health Solutions, which provides 24/7 access to mental health and substance use care throughout Arizona, and an associate professor of psychiatry at the University of Arizona. Dr. Balfour was named the Doctor of the Year by the National Council for Behavioral Health for her work at the Crisis Response Center in Tucson. And she received the Tucson Police Department Medal of Honor for her efforts to help law enforcement better serve the mentally ill population. She is a co-author of the book, People with Mental Illness in the Criminal Justice System, Answering a Cry for Help. And she serves on the board of directors of the American Association of Community Psychiatrists, the American Association for Emergency Psychiatry, and NAMI Southern Arizona. I don't know when she had time to come here today with all of those prestigious awards and opportunities. So join me in welcoming Dr. Margie Balfour.
Well, thank you so much for having me. I have to make sure I have somewhere to put my energy drink or else, So, yeah, it's really great to be here. And I was looking at your agenda, and it's amazing how much, y'all have learned so much just in the last couple of days. And so hopefully some of the stuff I'll talk about today will kind of help tie that together. How do I make it go? Oh, there it goes, okay. All right, so as far as why we're here, I think y'all are pretty much well versed in this. We're gonna talk a lot about what happens before they get to the court system, but our mental health system is set up already to have this huge inequity in how we deal with mental health and substance use emergencies, where if you have chest pain and you call 911, everyone expects that you're gonna get an ambulance that's filled with people who are trained in how to deal with your particular issue, and they take you to a facility where people are standing by, ready to be able to treat what it is that you have. And if you need further treatment, then they can admit you to a bed upstairs in the same hospital so that you get all of the care that you need. But unfortunately, if you have a mental health issue, and you call police, you call 911, you often get a law enforcement response. And my law enforcement buddies did vet the Chief Wiggins. They said that is okay and not offensive. So right from the very beginning, we have a system that is set up to have poor outcomes from the minute that person asks for help. And I think looking at your past agenda, I don't have to tell y'all too much about the consequences of having a justice response. With a quarter of officer-involved shootings involve someone with a mental health crisis. Jails, we all know, are not the place for people to get treatment. Also, though, the emergency room is not that much better. Over 60% of emergency rooms don't have any psychiatric care capability in them, which, that's pretty alarming. It's not like an ER can just go, well, we don't like diabetics, so we're just not gonna do diabetes. But that is what happens with people with mental health issues. And so what does happen to them is they end up waiting for long periods of time, hours, sometimes days, to be sent somewhere else to go to a psych hospital. Well, then they'll get the treatment they need. And so what happens during that time is what we call boarding in the emergency room, where people are there for long times without getting any treatment. Not surprisingly, they get agitated, they get violent, then sometimes they get arrested out of the hospital because they got violent because we weren't treating them. And then we criminalize, it's another way we criminalize their behavior. And it costs a lot. Some estimates are it's $2,300 to board someone in the emergency room per day, and people can stay for days. And then the outcomes are just terrible, right? So, it's great to divert people out of the justice system, but we also need to have a better option for them than the emergency room, because that's not the best place either. And sounds like y'all are familiar with the sequential intercept model. I'm going to be talking more about the 0 and 1 because we're trying, in the crisis world, we are trying to prevent people from ending up arrested in the justice system. And a lot of the, so Intercept 0 was actually added later, and a lot of that was based on the work in Pima County in southern Arizona, where I'm at, with the understanding that not only can crisis services divert people from law enforcement, but they also can prevent that law enforcement interaction altogether. Oops, why is it? Yeah, so. You may have heard, I think y'all had a talk on 988 earlier, but so SAMHSA, Substance Abuse and Mental Health Services Administration, has put out a vision for an alternative to this inequitable default system that we've had for so long, which is that we have a place where everyone has someone to call for mental health substance use crisis, and that's the new 988 number. And then, but we need the rest of that too. We need someone to respond, and we need a safe place for people to go. And so that kind of 3-pillar vision for crisis services is really, there's this huge expansion in crisis services because all of this. I like memes, so that's how I think in memes sometimes. But what this is kind of showing is that there's really a real convergence from a lot of different areas that's leading to us being kind of right at the beginning of this huge, unprecedented kind of lifetime, once-in-a-lifetime expansion in these crisis services, because you have 988, and with that, every single state has gotten planning grants on how to plan a crisis system for what happens after the call, those 3 pillars. And so every single state, there's at least somebody there with some money thinking about this stuff. This is, we live in divided times, but mental health is like one of the few bipartisan issues out there. And there's a lot that's happened in the last legislative session with lots of funding coming in to build out crisis services. There's a whole bunch of stuff percolating in this legislative session. And it's one of the few areas where you see people from both sides of the aisles getting together and work on stuff. And then even from the police reform movement, I mean, that's another divisive issue where there's, lots that people disagree on. But one thing kind of everybody agrees on is that police don't need to be the default first responders for mental health emergencies. And so you've got just a lot of interest in this. And so we're really at this precipice. It's a great opportunity. And so I was part of a group that put out this report from the National Council for Behavioral Health, or National Council for Mental Wellbeing now, that's called The Roadmap to the Ideal Crisis System. And you heard from Judge Leifman, I think, at the beginning of the conference, and he's on our group that wrote this. And it was actually, he was kind of one of the impetus for it, because he came to us with this sort of think tank of, all these mental health people, and was like, so, my legislators in Florida listen to me sometimes, and I keep telling them we need a crisis system, so where is it written out what that should look like? What's the ideal crisis system supposed to look like? And we were like, well, there isn't one. So we spent several years putting this together, and it came out right in the middle of all of this great crisis expansion. And so it's a useful tool, and you can download it, and you'll get this PowerPoint, I think. And but when we wrote it, we set out to kind of make some, simple but kind of bold statements, where one of them was that an excellent behavioral health crisis system is something that we should just all expect. It's an essential safety net service, just like EMS and police and fire. It's not something, well, after we're done with everything else, if we can find some money, we can have some kind of crisis services that operate Monday through Friday from 9 to 5. But we have to show that it saves money, and we don't talk like that for other sorts of health emergencies. You don't hear counties going, well, where can we move money away from our police budget to pay for these heart attack patients? That doesn't even make any sense. It's healthcare, and so it should be an essential safety net health service, just like everything else. And another point that we wanted to make was that we're talking about a crisis system, and so with all of this interest in crisis services, many communities are like, okay, we'll stand up a co-responder program, and and then, okay, now we've solved the problem. And it's a lot more than that. Just like emergency medical, it's a system. There's ambulances, and there's level 1 trauma centers and level 2 trauma centers, and all kinds of, there's 911, all of that. It's a whole system of things working together. Oops. Yeah. Where is it? Not okay. And also, when we put this together, a lot of people, when you talk about crisis, everyone wants to immediately jump to the services, the phones and the mobile and the facilities and stuff. And we actually made a point to not start with the services. So on our little pyramid here, we actually started with the foundation that you need to have all these services working together as a system. So, and that's around the governance and the oversight and how it's financed. And then you, on top of that foundation, then you layer the services, which the SAMHSA guidelines, if you've seen them, really talk a whole lot about the services, so it's complementary. And then we've got some self-assessment tools that communities can use to sort of start a discussion of, it's not meant to be like a tool to grade yourself, like, and be upset if you don't get a good score. The purpose of it is to start to go through some of these elements and see where you are, and then stimulate discussion and problem solving and planning. So I'd encourage y'all to take a look at that. And then when I talk about systems thinking, this is a Saturn V rocket, and I don't understand exactly how it all works, but this is not the Twitter rocket that blew up. It's the old school one. And a lot of people come and they want to see our crisis facility, for example, down in Tucson. And that would be like looking at that, that thing on the right, which I think is a fuel tank. And if you can look and understand how that piece works, but that's not going to help you. You're still not going to know how the whole rocket works. You really need to understand and be working on all these different parts together. Another way of looking at that is the left is an old slide from SAMHSA that really nicely lays out what a robust continuum of crisis services can look like. For having all the services for when people are in early crisis and, in their acute crisis, et cetera. And you really need all of those different components to be working together as a coordinated system so that the whole is more than the sum of its parts. And so what we've learned over the years in Arizona is that there's kind of 3 key ingredients for a system. Is you need accountability. So if we're saying that we want all of these crisis services to be working together towards common goals, well, what are those goals? Who determines those goals? What happens if different parts of the system aren't meeting those goals? Who holds them accountable? How is that overseen? We need collaboration. Collaboration is good for everything, but in mental health in particular, and crisis in particular, it crosses so many silos. It's not many healthcare fields where you invite, a physician to come talk to a room full of like court and judge people. That just shows how that's one silo that crisis services cross. Also talking about schools, and we're talking about kids and law enforcement and the health system and the EMS system and the mental health system. And so you really need both a structure where people can come together and problem solve, and then a culture of collaboration. I like to say you want the culture to be, well, let's figure out how to say yes rather than look for reasons to say no. And then data. I'm nerdy, so I like data. And if we're saying, well, we want to be working towards these common goals, we want to have these outcomes, well, we need the data to be able to determine where we're at with those. And we need the data to determine, are there gaps in the system where we could do better. And so a lot of people are looking to Arizona as a model for this. And, so why? Like, what is so special about Arizona? We do have a whole lot of venomous animals. That makes it special. But we're America's Australia. But another reason is because over the years, we've developed a really robust crisis system over the last 20, 30 years. And a lot of that is because those concepts I was talking about before are kind of baked into our structure. And I'm going to spend a little bit of time on it because, I'm not saying every single state, every state does its Medicaid and everything differently, but it illustrates some key concepts to think about when designing a system. And in Arizona, the crisis system is built on the backbone of Medicaid. And I saw you had your Medicaid people here yesterday, so that's great that you're talking to them. And And Arizona is an interesting state. I moved there from Texas about 9 years ago. And when I got there, I was like, oh, this is so great. There's all this Medicaid expansion. And I see y'all are an expansion state too, so yay. And there's all these great crisis services. And the name of the Medicaid department is even named Access. It's all about access to care. That is so cool. If you read the tiny type up there, I then learned that Access stands for Arizona Healthcare Cost Containment System. So it was not like the warm, fuzzy, what I thought it was. But it actually explains a lot about, why did this weird red state full of all these venomous animals develop this amazing crisis system? And part of that is some of the history of it is Arizona was the last state to ever have Medicaid. Not expansion, but just like any Medicaid. It wasn't until the 80s, and partially due to a lawsuit called Arnold versus Sarn. Since I'm here with a bunch of lawyers, y'all could actually look that up. And but it was a lawsuit on behalf of people with serious mental illness, and part of that, like a 30-year court oversight settlement. And part of what they needed to do to meet the terms of that settlement to provide services to people was they finally did have to buy into Medicaid. And the story that I heard, because it was before my time, was that the Goldwater Republicans of Arizona would only pass the law that said we'll do Medicaid if the words cost containment were the name of the department. So they did that. And then the first thing they did, though, is they turned around and they asked the feds for a statewide managed care waiver, which I think Kentucky has one of these now. And Arizona was the first state ever to do that. And if you're not like a Medicaid policy wonk, what that means is you go to CMS, the federal government, and you say, give me the money that you would have given us for Medicaid, and give us the flexibility to contract to like an organization, like a managed care organization, to administer it, and give us some flexibility on how they do that. And then in return, they have to prove that they spent the same amount of money they would have otherwise, or less, and that the outcomes are the same as they would have been otherwise, or better. So from the very beginning, there's never been just regular fee-for-service Medicaid. It's always been under this system, and it means that from the very beginning, people had to think of Medicaid as a system in terms of cost and outcomes. And crisis services are very much aligned with a model like that, because if you think about, like, what do I want as a clinician? I want my patients to not be in jail. I want them to not be locked up in the hospital if they don't need to be. And I want them to not be in the emergency room. If you're paying for stuff, you want those same things, because it's a lot less expensive to be doing well in community-based care than it is to be in jails and hospitals and emergency rooms. So over the years, it's made sense to invest in crisis services. So whether you're coming at it from a clinical point of view, from a social justice point of view, or a responsible stewardship of taxpayer funds point of view, it makes sense to be having these crisis services. And the way that we have it structured, the other innovation that they did is they blend together, they braid together multiple funding streams. And I'm not sure how it is in Kentucky, but in many states, there's like a Medicaid department, and then there's another department in the state, like some kind of Department of Behavioral Health. And so the Medicaid department has all the Medicaid money, and then the behavioral health department has the money that comes down from SAMHSA, from the federal government. Maybe there might be like state general fund monies for mental health and crisis and indigent care and things like that. And so then you've got like two separate kind of systems. What Arizona does is they take all those funds and they braid them together, and it goes through our Medicaid department, Access, with its warm and fuzzy name. And then they put out for competitive bid to be they divide the state into regions. So there's the north, there's the central, which is Phoenix, and the south, which is Tucson, which is where I'm at. And then they put out a competitive bid to be the regional behavioral health authority, and then they get all that money, and then they contract with providers like us. So we're like a facility provider, there's mobile crisis providers, there's the phone providers and stuff like that. That's all done via contracting. And everyone is entitled to crisis services, regardless of whether you have insurance or what insurance you have, or if you don't. And the way they do that is because we, as crisis providers, we all get paid up front, kind of like what they call the firehouse model. You're not paying me to see somebody at 2 in the morning and then send a bill and get paid 90 days later. You're paying me up front to be there at 2 in the morning in case there is someone who needs to be seen. And then because so if you happen to come through Arizona and it's too hot and you freak out and need some crisis services, then you would be covered. Anybody, y'all, as you are on Arizona soil and you have a crisis, at least that first 24 hours of crisis is covered for anyone, regardless of payer. And so the way they do that is because we get paid up front, we don't have to worry then. We treat whoever comes through our doors, and then on the back end, when we send our info back up to the Regional Behavioral Health Authority, they go, oh, these 500 people that you saw last month, they had Medicaid. We're going to put them on the Medicaid bucket in our spreadsheet. And these 200 people didn't have Medicaid, but the SAMHSA block grant will cover those. So we're going to put them in that bucket on the spreadsheet. These people who didn't have any insurance at all, and there's some state funds for that, so we'll put them there. So that way everyone gets their services. One sort of point of advocacy is if you have private insurance like Blue Cross Blue Shield, like most private insurance, and Medicare does not yet pay for any of these crisis services anywhere. And so if someone with Blue Cross comes through, ultimately they get their services, but their funding for that comes out of the bucket for indigent people. So you should tell your legislatures to fix that. Another way to look at it, when I was talking about kind of these incentives where things, we want to do care in the least restrictive setting, so in the community as much as possible, and how that also tends to be the least costly setting, you can look at your services along a continuum like that. And so this graphic is circulated around. It's in some of the SAMHSA stuff, but it's actually based on Southern Arizona data. And so this kind of shows how you have your services along that continuum. The most community-oriented, community-integrated thing, least restrictive thing, is to pick up the phone and call somebody or text somebody. And so that's our crisis line, which now 988 points to. So for Pima County, for example, which is about 1.2 million people, the crisis line gets about 7,000 calls a month from Pima County people. And they're able to resolve 80% of those on the phone. And they do that via telephonic counseling. They can do safety plans with people. But another thing, because this is like a coordinated system, the Regional Behavioral Health Authority that contracts with them also contracts with clinics, and they tell the clinics that they are required to have crisis appointments, and they're required to put that in the software that then the crisis line has. So at 2 a.m, part of what helps resolve your crisis is from the phone person to be able to say, oh, well, we got you an appointment at this clinic at 11:30 tomorrow. They can do that. If they can't resolve the crisis, then they're able to dispatch mobile crisis teams. And so there's about 16 mobile crisis teams. They operate 24/7. They're clinician-only teams, so these are not like police co-responder teams. It's either 2 clinicians or a clinician and a peer. And they respond within an hour. If they do a face-to-face intervention in the fields, they resolve that crisis about 70% of the time. And then for those that need a still higher level of intervention, we have crisis facilities. And we operate the main one for Pima County, also one in Phoenix. And I'll talk about those in more detail in a minute, but they are set up for anyone to be able to walk in, or they can be brought by mobile team, or they can be brought by police. And most of the people going through there, about 60 to 70%, within 24 hours have their crisis resolved, and they don't have to go on to the hospital. And then after the crisis, there's various services to help make sure that people get connected to the care they need. There's some post-crisis wraparound services. There are lower acuity crisis facilities like crisis residential or peer respite that people can either access directly if they're kind of in a lower level crisis, or we can use those as step down to help people transition back out to the community. And then talking about sequential intercept 0 and 1, where the goal of those, of those intercepts is to make it really easy for law enforcement to divert people into treatment. So its system is designed so that every point along here, we try to make it easy for law enforcement. There's this culture of we treat law enforcement as a preferred customer, because just like the patients are our customer, law enforcement's our customer, because we want to make it easy for them to have their people access care. And so there's things built in like that. So for example, the crisis line, they have staff that is physically co-located in City of Tucson 911, and they're able to intercept calls. About 1,500 calls a month, they're able to identify as behavioral health calls, have the clinical call takers take them, and then if they need to dispatch mobile crisis and everything, it goes down this whole clinical pathway, and it never has any justice involvement or law enforcement involvement. The mobile teams, So, I mentioned how we're all done, via contracting. And so some of these incentives are baked into the contract. So for example, if I'm at my house and I call the crisis line and they need to send a mobile team to me, they have an hour to get to me per their contract. But if I'm a police officer out in the field and I'm trying to serve a civil commitment pickup order because someone's suicidal and they won't come out of their house, then, in many jurisdictions, that is a call to the SWAT team, which my cop buddy likes to say, if they're not going to come out for his 2 plainclothes guys, they're not going to come out for 30 guys in a tank. So, why do we do that? And so instead, they have the mobile team come help them. And it's written in the mobile team's contracts that that they have, it's an hour to get to me at my house, but it's a half hour to get to law enforcement if they need them out in the field. And then our crisis facilities are really set up for fast and easy drop-off where law enforcement's never turned away and that they are back out on the street in 5 or 10 minutes. And this is kind of an example of how some of those concepts can cascade down all the way from the state level. Because if you think about it too, why would the Medicaid department care about reducing justice involvement? I mean, besides just being like a good human. If you think about it though, from a purely financial point of view, when someone goes into jail, their Medicaid is turned off. So they're off your Medicaid spreadsheet. But ultimately, the money all comes from the same place, which is us taxpayers. And so our past governor did this smart government initiative where he had the directors of different departments in the state government share their budgets and come up with these cross-departmental goals. And so that is where one of this goal of reducing justice involvement for people with mental illness came from. And so then that goal was up at the department head level. So then when Access, our Medicaid, put out its RFPs for the regional behavioral health authorities to bid on, one of the questions on those applications was, how are you going to reduce justice involvement for your people? And so they had to answer that. And so then when they then contract with us, that's how you get incentives, like you have to respond faster if you're mobile crisis when the police call for you. They also have things where if people are in jail, they send people to go meet with them before they're released so that they can make sure that they have a good plan for when they get out. And so that's how a big kind of overarching state goal can trickle down all the way down to the provider level. I'm going to skip that. And so now I'm going to kind of back up a little bit and talk about some national trends and what's going on in these 3 pillars, but then use some Arizona examples to kind of show how they're can be working in practice. And so I think you had a whole session on 988, right? I think, okay. So you all know what that is, and that it's still not quite 1 year old. And it's also just really the beginning of, of a much, hopefully what will be a much larger, more robust system. Because now, if you think about, when you think about 911, you can't even think about 911 without your brain automatically also thinking about all that comes with it, ambulances and trauma centers and all that kind of stuff. And the first 911 call was in 1968. So all of that other stuff didn't happen overnight. It took a long time. And we're kind of in that phase right now for 988, but hopefully we've learned a lot over the years, and so it will be a much faster growth. But 988 is really just the beginning. And if you actually look at the number of calls, so what 988 did was it took what was the existing National Suicide Prevention Lifeline and mapped 988 to it as a first step. And so that's kind of like that green over there, where it's about 3 billion calls a year. But there's a whole bunch of other crisis lines, like in 211 lines and things like that people have been historically using for crisis type stuff, and there's a whole lot more calls there. And then it's estimated that maybe a conservative estimate that 10% of 911 calls involve behavioral health. And so if you look at all of that, it's really could be up to 40 million calls per year. And so there's a whole lot more that needs to be done to start to capture those calls. Right after 988 came out, I don't know if you remember any of this, but there was a lot of social media controversy where people were posting stuff saying, don't call 988, don't use it, don't share it, don't trust it. They're going to send the police after you. And that is a valid concern. People call for help and they want to get help, then they don't want to get a police response. So SAMHSA quickly put out some stats showing that they only activated 911 in 2% of those calls, and half of those the caller was collaborating with them. But that's an average over the entire country. And how helpful is that to talking to real people in your communities? And so in order to just kind of address that, there's, it really depends on where you live and what services that are available and how it's integrated with 911. A lot of call centers are starting to try to integrate into 911, all the way, and no one really quite knows what's the best model. So people do all the way from having them physically co-located like they have in Tucson, to just having protocols, so how those calls can be transferred, but no one's physically there doing it. So there's lots of models that things are figuring out. But what it really comes down to, though, is what happens when you call 988 is highly dependent on where you live. This is a map that shows the percentage of calls that state's 988 is able to answer in that same state versus it's too busy and they roll it over to another state. And the point of this is that it's highly variable. And then it depends on what services are available in your community. If all you have in your community is 988 and you don't have any mobile and you don't have any crisis facilities and you don't have any co-responders and things like that, well, then it's much more likely that if you do call 988 and you have a severe crisis that needs some kind of in-person intervention, that you are going to get law enforcement. So the take-home message for that is it's really important to start building these crisis response systems so that people are getting what we call a health first response, where you're getting you're getting clinical professionals, just like you would expect. You wouldn't expect the police to come respond to your heart attack. Now, sometimes the police may go with an ambulance to clear a scene, but the actual response needs to be a clinical response. And so, so mobile teams then. And there's lots of different models for that as well. A lot of these crisis services have flown under, there's the major theme of it is that there's not really good national standards for this stuff yet. And the reason why is because, like I mentioned before, Medicare doesn't pay for it, private insurance doesn't pay for it. It's forever has sort of been the responsibility of the states, and every state does things differently. They say you've seen one state behavioral health system, you've seen one state behavioral health system. And so we're starting to, I think that's something that's going to be happening in the next few years, is starting to actually coalesce around some national standards and even just describing what's going on around the country. So this was a survey that a couple of colleagues of mine did on what do your mobile teams look like? And I put the M&Ms on there before M&Ms got controversial, because whoever knew that M&Ms would be controversial. But this shows kind of what is the composition of your mobile teams. And most of them are clinician mobile teams. And so those could be 2 clinicians, it could be a master's clinician and a bachelor's clinician, it could be a clinician and a peer. In some of the rural areas, you're seeing a clinician and maybe their backup or their licensed oversight is via an iPad or something in these more rural areas. But those, those are your clinical mobile teams. There's a whole bunch of different flavors of co-responder teams. Some of these are an officer and a clinician. Some of them, the first responder is EMS and a clinician. There are multidisciplinary teams that actually have all 3. So they have an officer and a clinician and EMS. As far as what model, should you pick? And that's kind of the question every community is kind of grappling with. And the big question is, what should the role of police be? And so we're starting to get some research coming out around that, where they're asking people, what do you prefer when someone responds? And most people prefer either a clinical response, clinician only, or to at least have a clinician with the law enforcement officer. Interestingly, a recent study came out where it was showing that the people in crisis were preferring the clinical teams, but the families were actually preferring to have law enforcement there as well. So all of that is still kind of, being worked out. But I think everyone agrees, though, that it should be a health-first response, and that it's you do need clinical care. You shouldn't just have law enforcement responding. There's different strategies for when you're designing crisis systems on how to do that. There's links here for a couple of resources because another thing that's important too is you want your response. I think Sarah Vinson was here too, because y'all had like an amazing lineup. But talking about how you want an equitable response, and you want a response with people who are responding that look like and can identify with the communities that they're serving. And so involving peers in your workforce is a really good strategy to do that. And so just the take-home message of this is, all these different teams do all these different things. They may have different criteria for who they will see and who they won't see. There's different considerations for doing this in rural areas versus urban areas, et cetera. And the take-home message is that it's not a one-size-fits-all. You need the whole bowl of M&Ms. And you may have different types of teams to respond to different types of things. And I'll show you later kind of how we've organized that in Tucson. And so then a safe place to go. So that's the third pillar of SAMHSA's vision. And there's a list of some of the types of facilities you may see out there. And then a quote that me and a colleague wrote in a recent paper we were trying to talk about all these different types of facilities, where the term right now, because of this lack of standards, the term crisis stabilization unit is pretty much meaningless. Like if I went somewhere where there was people from all 10 different states, and I said, oh, do you have CSUs in your community? And they would go, yes. And it's like, well, describe to me what it is. And you would get 10 totally different answers. Even within states, even in Arizona, we use the same billing code for our really high acuity crisis center as the peer-run living room in Yuma. So, there's really not standards for how these different things are different. This was my kind of attempt to start to put these in some buckets, because it's really important to understand what the different facilities can and can't do for a variety of reasons. One is you want to make sure that you're sending the right people to the right facility. Otherwise, you could have unsafe conditions where you're sending someone who is suicidal to a facility that can't handle suicidal people or agitated people. Or if you have some people that they just need to talk to a peer and have a cup of coffee and a safe place to stay overnight, and having them be in a more institutional setting is going to be kind of like overkill and maybe make them not want to go seek help. So we need to have a full range, kind of like how we have in medicine, we have trauma centers, level 1 trauma center, level 2 trauma center, like we all know what that means. So this was kind of our attempts to start to put these into some buckets where we talk about the acuity of the people that you're serving and the intensity of the services that you're providing. And so over here on the left is our high acuity people. And so these are people who would mostly be boarding in emergency rooms waiting to go to the hospital, people who are danger to self, danger to others, psychotic, agitated, intoxicated, in withdrawal, who need kind of a hospital level amount of safety and treatment. On the other end of the spectrum, you have like peer-run respites and living rooms where it's really, what they really need is engagement, psychosocial interventions, help with social determinants, and you don't really need all that medical nursing as much. The difficult group is the ones in the middle, because that could be anything, and you have to, determine from each facility. It's important to get clear criteria for who can be served here, who can't be served here, so that you're not sending people there and causing an unsafe condition, but also too, so that the community has its expectations aligned, because we see this often where the community got together, they built a facility, and the community expected it to take one group of population, and then the facility was not able to take that group of population. And so, people are too acute, too agitated, too violent, whatever. And those people are still ending up in jails and emergency rooms, and then the community's like, well, why do we spend money on this crisis center? We still have people in our jails and emergency rooms. So just a little bit about our center in Tucson, because it gets a lot of national attention as a model, and especially with how we all interact with law enforcement as well. And so Pima County built the Crisis Response Center back in 2011, and we've been operating it since 2014. And important thing to note is the county built the building, and they lease it to that regional behavioral health authority that we have for $1 a year, which is like the best rent ever. And they pay to maintain the building, but the services themselves are funded via that whole Medicaid structure that I showed before. And that's important because as communities and counties are figuring out like how are we gonna do this and how we're gonna make it sustainable, the county didn't have to come up with a way to pay for ongoing services for like the rest of time. They did the capital expense for the building, but the services, it's healthcare. This is another one of my kind of parody soapboxes is mental health and substance use care are healthcare. It should be paid for out of the healthcare system. It shouldn't be like from, trying to cobble together money for other, stuff that's not healthcare from county and municipal and, budgets. And so that's why it's sustainable, is because it's a healthcare covered service. We see about 10,000 adults, 2,200 kids per year. We have a couple different levels of care for both of those. So there's a 24/7 urgent care walk-in for both. So anyone can walk in and say, I'm new to town, I need to be connected to services, or I've missed my appointment, I need a med refill, or I'm not doing well and I can't get in, in time. And so those folks are seen there, seen by a case manager. We have 24/7 staffing of either psychiatrist, nurse practitioner, and so they can get a med refill if they need to. And those folks are usually in and out in about 2 hours, is the median. And then we have our overnight observation unit, which I'll talk about in more detail. And then for people who need to stay a little bit longer, we have, for adults, we have a 15-bed subacute inpatient unit. It's part of the school campus. It's basically on the campus of the county hospital. We're connected via a breezeway to the emergency room, so if people have medical emergencies, we can get them over quickly. And when people end up in the ER and they have behavioral health issues, they can send them back over to us. And it's also the bond that built the CRC also built a 66-bed inpatient psych hospital, which is where the majority of the civil commitment hearings and stuff happen in that hospital. And there's a mental health court right there. And before COVID, before everything became virtual, they would hold court and stuff in there. I think they even do some like warrant resolution and stuff in there too. So it's even not all civil commitment. One of the most important things for having these facilities is that whole idea of, remember I was talking about treating law enforcement as a preferred customer? So how many people here have heard of CIT training for the cop? Yeah. So the people who created CIT like to remind everyone that CIT is not just the training. That's the big centerpiece of it, but it really is meant to be a community response towards mental health. And a big piece of that is if you're training law enforcement officers to recognize mental illness, de-escalate people, and divert them to treatment, their first question is going to be, well, divert to what? Because like I was mentioning, the ER, we're trying to tell them not to take them to jail. The ER is not really a good option. Oftentimes, the police have to wait with those patients, like especially if they're involuntary. They'll have them wait for the whole 2 days that they're waiting to ship them off to a psych hospital somewhere. And so they need, they need what's in the CIT model they call a receiving center. And then if you dig up the original CIT manifesto from the 90s, it actually lays out what would that ideal mental health receiving facility look like. And I highlighted those two in the middle because that is what we see in different communities where those two are the hardest, and that's what people struggle with. And that's the minimal turnaround time and the no clinical barriers to care. So what does that actually mean? That means that these facilities need to take everybody. And behavioral health, we have this well-deserved reputation of being difficult to access, where it's easier to get into heaven than to get into psychiatric facility. You can't be too agitated, you can't be too violent, you can't be too acute, you can't be too intoxicated, all these different exclusion criterias. And our philosophy is that those really agitated, acute people, we want them in our facility. They're the most in need of specialized care, so why would you ever send them to an emergency room? And we do it without security. Because another thing is, we have really well-trained, we do a whole lot of training with our behavioral health techs and the rest, and our peers and our nurses and our providers and our whole staff. So if we do all of this training on de-escalation, and then if we do have to get physical, like lots of training on how to do that in a safe, patient-informed way, then why would we default to a security guard with less training? So that makes no sense to us. We don't use security. And then the other thing is that we get the police in and out in 5 to 10 minutes. I think our median is usually around 6 minutes. And then we never turn them away. So sometimes that's what we mean by no wrong door. So yeah, sometimes they bring us someone who maybe they would have been better suited for the detox place that's across town, but that's fine. We can do detox. If they need to get back over, if they need to get over there for continued substance use treatment, we'll arrange that. We're not going to tell the officer, put them in the back of your car, take them somewhere else. People always ask about medical emergencies. Well, what happens if they bring you somebody medically unstable? Well, first of all, the police, they don't get enough credit they're pretty good at knowing who needs to go to the ER and who doesn't. So it's pretty rare they bring us people that really, they shouldn't have brought us. We do sometimes, though, find things where someone needs to go to the emergency room, and so we'll get them transferred. It's about 4% that we send over for some kind of medical evaluation, and then they come back. It's nice that we're located next to an ED here, but it's not necessary. Our Phoenix facility is not, and the numbers are about still the same. And then, if someone does come in and they do have a true medical emergency, what makes more sense? To have some clinical person eyeball that patient and then determine that they are medically unstable, and then say, hey, medically untrained law enforcement officer, put that person in the back of your unmedical cop car and drive them off our property because we don't want the liability. I mean, that sounds like a lot of liability to me when you do that. So, our philosophy is we're all trained in basic life support. We can get them stabilized, get them moved, and also our CMO likes to remind us psychiatrists that we did go to medical school, so we can treat things like high blood pressure and diabetes, and so we don't require some kind of blanket medical clearance before they come to us. We take people directly off the street. Another thing for law enforcement that's important is to have we have a dedicated entrance for them. We have a secure gated sally port. So that's again for a couple of reasons. One, it helps law enforcement get in and out of there really quickly. They have everything they need back there, because the other thing law enforcement doesn't like is they don't like being asked to take their guns off. I don't know if you ever tried that, but they don't like it. And so, they'd be traipsing across the building to try to, make a copy or go to the restroom and get some water, and our staff would be hassling them to take their guns off and everything. So we're like, no, we're gonna get them everything they need right back there. So I have a little office that has a computer with all their forms on it. There's donuts on National Donut Day. There's Keurig back there, refreshments, their own bathroom. And so that way they can do all the stuff they need without, coming from the hot, enjoy the air conditioning for a bit, but without, having to take their guns off. And then the other thing, too, is that officers don't our officers are really bought into this, and they have empathy and compassion for the people that they're bringing. And in some other places, they would have to come in the front door, with the person in handcuffs and parade them through the waiting room in front of, everyone else who's all gawking at them. And, that's really stigmatizing and so by coming in the separate entrance, the other patients don't know who came in via law enforcement and who didn't. So that stigma is one way to get rid of that. And then, we've been part of several different research studies over the years, and this was a study that was done looking at Tucson 911 and Tucson Police. And in that study, they showed that the Tucson Police were less likely to arrest people for mental health calls. And when they did the qualitative part of that study, the officers attributed it to having a place like the CRC where they could easily drop people off. It was easier to not arrest them. As far as what happens on the observation unit, so it's an open design, so it's not like individual rooms like an emergency room would be. And there's a few different reasons for that. One is if you think about if people are coming in and they're danger to self, danger to other potentially, how do you keep them safe as you observe them? So it's an open area so that all of our staff can always have eyes on everyone to make sure everyone's safe. The other reason is, if you think about what happens when you go to an emergency room because you're suicidal, they put you in a room by yourself, they take all the stuff out of it, they take all your stuff away, they hire a sitter who's supposed to sit there and watch you but not talk to you about why you're there, and then you just stay in isolation for hours or sometimes even days. And that is not very therapeutic. We knew before we even had meds that having social interaction had therapeutic value to it. That's why if you go to a psych unit today, they all have that kind of common living room area. And so people can get up and walk around, and there's activities going on. There's groups. Our peers are meeting with people. And so, there's that kind of stuff going around. And then also, it gives us the flexibility to flex up because we never say no to the police. We're never full. So sometimes we'll have surges where we go above what we're technically licensed for, and then we're able to move things around, and then we, go back down. As far as what actually happens on that unit, so we are really clear that these are not holding areas, or we're not like holding people to transfer them off somewhere else to a psych unit. Like we never go, oh, you're really sick. Like let's put you on the observation unit and start looking for you an inpatient bed. We go, oh, you need to be on the observation unit. Now we're going to work together to try to figure out how to resolve your crisis. And so we start treatment. So our door-to-doctor time is about 90 minutes, and so we can start medications. We have our case managers who are on the phones, the families and clinics, trying to find out what's going on and figure out what social determinants issues need to be addressed. What do we need to do for care coordination? Our peers are working with people. We have a lot of people on detox, so our nurses are administering detox protocols. We can start Suboxone. And then we reevaluate them at some point during that 23 hours, and because we've assumed we're going to resolve the crisis. Only if we can't, then at that point we'll start looking for them an inpatient bed somewhere. So about 60% we're able to stabilize so that they don't need to go to the hospital. We get them either into rehab or a step down like crisis residential or back home, but with the services that they need. And we also look at people who come in involuntary, because we see a lot of involuntary people, and whether or not they're going to the hospital or they're going home, we're also working to convert them to voluntary status so they're engaged in their treatment. And so that's another one of our core outcome measures. We see a lot of substance use. Substance use has been integrated for so long in Arizona. I often just forget to think about it separately, but it's having the ability to treat both co-occurring mental health and substance use is super important because they go hand in hand. So our data shows that 15% of people come in saying, I'm here for a substance use reason. But then if you look at their tox screens and their diagnosis, it's about 2/3 actually have a substance use co-occurring issue. And most of that of what we're seeing is meth, followed by alcohol. Opiates, though, opiates is I'm sure, underrepresented because we can't test for fentanyl right now. There's not a urine drug test that can be done like in an outpatient type setting that will test for fentanyl. And we're seeing it in everything now these days, which I'm sure you are too. And then law enforcement. So, we don't do what we do in a vacuum. We are very fortunate to have a very progressive police department down in Tucson. And they have, this is kind of their approach towards mental health training, law enforcement training. So, and it comes all the way down from the leadership. The leadership is truly bought in. So they've got like things in their policies, like, they don't have to handcuff people with mental illness if they don't think it's indicated and things like that. As far as training goes, everybody gets 8 hours of mental health first aid training. It's in the academy, and they went back and retrained everyone who'd already been through the academy. CIT training is, that's the 40-hour training, is voluntary. So there's research that shows that CIT works better if it's something that officers voluntarily participate in versus like being voluntold or punished. Your punishment is, you have to go do CIT. That doesn't work as well. But they've done all these things to incentivize it so the officers want it. So there's certain like promotions you can't get unless you have it and things like that. And then one of their really cool innovations is they have, in addition, these specialized teams, which I'll talk about in a second. And they do only mental health, or they do, a lot of mental health, like your SWAT and your hostage negotiators. And then they get advanced training. So they get training in things like motivational interviewing and trauma-informed care. And so they have a really, and then they can act as resources for the other officers too. So they have a really robust training program. And then this is kind of what we have evolved over the years. We're talking about co-responders, and we've really moved away from thinking in terms of a co-response and more of a collaborative response, where you have different options for the different situations. And if you think about crisis, so we often are talking about the orange part of crisis, where there's an acute event, you need an intervention right now, it's urgent, it's kind of a one-time thing. And then, but then after the crisis, as it resolves, people need to be connected to the services they're going to need. Otherwise, things are going to escalate into another crisis. And so there's opportunity to do follow-up and outreach and things like that to get people connected and to prevent another crisis from happening. And so on the orange side, so I like my little infographics, but so you've got urgency, on one axis, and then safety risk on the other one. And so over on the orange side, if there's not a safety risk, then the crisis care should be completely the responsibility of the mental health system. Law enforcement, courts, all that should really never be involved. And so that's where you get those SAMHSA 3 pillars, someone to call and someone to respond and somewhere to go. If there is a safety concern, then there's different ways for law enforcement and the mental health system to collaborate. So I mentioned, for example, they, instead of calling the SWAT team out for people who won't come out of their house, they have the mobile team come help them out. Sometimes the fastest thing is, there's a dangerous situation with a 911 call with someone who's suicidal and they also have a gun, et cetera. They're going to send law enforcement for that, but and just CIT trained officer, and then bring them to the CRC. On that blue part, then it's sort of similar. When you're thinking about outreach and follow-up, if there's no safety issue, no criminal issue, then law enforcement shouldn't be involved. That should be, the courts, really shouldn't be involved. It should be the responsibility of the healthcare system to get people into the post-crisis care that they need. And we have something called second responders, which are like peer wraparound that can check on people after. Make sure they're connected. We have a transitions clinic that people can go to for 2 weeks, couple of months after the crisis to get them more stable. But then if there is some kind of safety or criminal or whatever issue, again, there's different ways that law enforcement can collaborate. And this is where in our system, more like co-response type stuff made more sense. And so there's a specialty mental health support team that works with cases where there's a threat to public safety. And so there's a peer that goes with these special officers that don't do anything else and check up on those people. There's a substance use resource team where there's a peer that goes with officers to follow up after overdoses or people that they have the option to not arrest people for drugs and paraphernalia, and so we'll follow up with those. And then there's a homeless outreach team that does outreach in the parks. And so that's, again, it's a peer that goes with the officers out into the parks to do outreach and engagement. And so all of this together then is kind of how, so that's why we call it a collaborative response and not a co-response, because there's all these different ways to do it depending on that individual situation. Tucson Police, this is their mental health support team, and this was actually, they created this in the aftermath of the 2011 shooting that happened in Tucson where Congresswoman Gabby Giffords was shot. And so that person, Jared Loeffner, had bumped up against law enforcement a couple different times. And so they really kind of did an examination of how did this guy fall through the cracks? What do we miss? How do we deal with our mental health population that we serve? And one of the things that they noted was that there's these orders to go pick people up for civil commitment for an evaluation, or maybe they're already on like an outpatient commitment, and there's an order to pick them up. And so law enforcement is supposed to serve those and go get them. And they realized they weren't tracking them. So they didn't even know how many, and they expire after 14 days. And they didn't even know how many of those they were serving before they expired. They estimated maybe 20%. And so that's already a lot of people falling through the cracks. They would just fax them to the nearest police substation, and then they'd give it to the rookie because no one wanted to go do the mental health pickup. And they knock on the door, person's not there. It's like the FedEx guy that knocks and then leaves before you can say that you're really there. And so they weren't really being served. And so they created a specialized team that does nothing but that. They're plain clothes in unmarked cars. And now they serve like virtually all of them. And they've done thousands of these with like only 1 or 2 uses of force over all that time. And because that's all that they do. And they also were able to recognize patterns and let people in the mental health system know, like, hey, we've been out to your guy's house multiple times. There's like things going on. And so that's one thing that they do. Then they added detectives. And this really gets at that question they were trying to answer in the first place, which is, how did a guy like Jared Loeffner fall through the cracks? And so and sometimes when my police buddies explain things to me, I'm like, oh, that makes sense. But it turns out that like in police world, that's like a really radical shift from how they normally think. And this is kind of one of those things. Because what they're doing is they're investigating things that aren't crimes. Because if you get robbed, you get a robbery detective. There's a murder, there's a homicide detective. But there's not typically a my neighbor's acting weird and I'm concerned detective, because that's not a crime. And so they do that now. So they have a couple detectives, and there's certain codes on calls that will flag them to review, or anyone can just say, this seems weird, and flag it, and then they investigate those. And then their goal is, and when they first started doing this too, they had to earn a lot of trust from the mental health community, because at first, they'd try to call the clinic or whatever that they might have been attached to, and they'd be like, I'm not going to tell you about my person so you can arrest them. And they're like, no, we're trying not to arrest them. And that's really what they're trying to do. They're trying to see, is that person in services and needs to be reconnected? Does the team know what all is, because there's a lot that happens that the team never knows, because it's all happening out in the community and law enforcement's interacting with them, and that never gets back to their psychiatrist or their case manager. And so that's their goal, is to connect those folks to treatment. Some of their outcomes is, so that mental health support team, when they had a mobile team going with them to help them, they were able to decrease the amount of times that they would then fill out the involuntary paperwork to get them involuntary hospitalized. It was they went down from 60% of those interactions to 20% of those ones that those detectives were doing. The substance use team has done, it's been like more than 2 years now, but thousands of people they've connected to treatment, and they've got some really good data showing that it's not the same 2,000 people over and over again, that they're getting people connected. And then the housing outreach team, is really working on interfacing with those folks and engaging them and getting them housed. Some more data, because I like data. How much time do I have? Time guy. How much time do I got? Okay, cool. So I'll go through this quickly so there'll be time for questions. I was part of the National Council for Behavioral Health, or for Mental Wellbeing. We recently put out a companion piece to the roadmap that talks about outcome measures for quality services, or for crisis services. And so there's a link to that if you want to take a look at it. We talked about kind of 2 different frameworks. One is to go through the system, like how people flow through the system, and then metrics around how well does that happen. Like, for example, what percentage of the 911 calls are being sent over to the crisis line, and then what percent of them get sent back. And then we also looked at kind of values that that a crisis system should have, and having metrics that reflect that value. So for example, the L is like the least restrictive. In that schematic I showed you before, every component of the system is measuring how do they adhere to that value by getting people stabilized in a more community-based setting versus kicking them up to a higher level of care. And then just importantly, we also mentioned equitable, and that where it's really important to start to stratify all these various different outcomes by race and ethnicity and other groups that you might want to look at to see if there are disparities so that you can act on those. So that's more of a cross-cutting measure. We did something similar for our facilities. So these are the metrics that we use in our crisis facilities, where we articulate what's the value. We want timely care, so we have measures around that. Our least restrictive, we look at that community disposition rate and that conversion to voluntary rate, for example. Measures around partnership, that's why we measure how fast we get law enforcement out, because that's a very metric that's important to them. So you can see, like, this is, they're bringing us lots of folks. This shows law enforcement drop-offs, and the dark part of the bars, the blue ones are adults, and then the orange ones are kids. But you're seeing that so the light blue is people that they're bringing us in voluntarily. Because usually when the police bring people to crisis centers and stuff like this, they're bringing them under whatever your involuntary hold is. But the Tucson Police are really good at engaging with people and getting people to come with them voluntarily and say, hey, there's somewhere I can bring you for treatment. Would you like to go? One of our doctors calls it the Uber Police. But we think it's great because they're actually they've been able to get people to want to come into treatment. And then the circles are the turnaround time for the law enforcement officers. This is some data that Tucson Police did. Everyone, when people do get arrested, there are types of people, the people that ought to be in crisis care instead of jail. When they do get arrested, it's for these nuisance crime things, like vagrants. I still don't know what vagrancy is. And we were working with a group in Ohio, and they had aggressive jaywalking. So I guess every community has their things that they pick people up in for. But you can see those have gone down as they've really beefed up their whole mental health programs. And then this is that SWAT data. Besides the fact that it's kind of stupid to send the SWAT team for things like that, and the SWAT team hates it too because they're just told to just sit there and not do anything, it costs a lot to send the SWAT team out. And so when you're trying to make a case for doing this sort of work, that's a pretty compelling one, is you can, each one of these is $15,000 because of all the overtime. And this is data from the substance use deflection, which shows the arrest is in red, and you can see how those decrease. And the officers like it. So it takes, the numbers there, but it takes, 49 minutes to do a deflection versus 77 to bring someone to jail. So the officers like it because it's been made easier to, kind of the underlying philosophy is let's make it easy for people to do the right thing. This was analysis that was done in Phoenix, which has a very similar crisis system, but bigger, and that looks at the return on investment and the savings. And the savings from doing this come from various different places. It comes from saved hospital stays. It comes from saved emergency room visits and the boarding in emergency rooms. But also, too, because in most places, when police bring patients to the emergency room and they make those officers wait with them, you can calculate the FTE of officer time, of putting officers back on the street, which in this time of short staffing is also a compelling argument. This is another analysis that Arizona did of its statewide, the Medicaid department did, showing the return on investment of what they're spending in crisis services and then the savings that they get out of it. And then also just noted that where the money comes from, no Medicare and no commercial. And so there are bills in Congress to require crisis services to be covered. So if you're doing any advocacy, that's an important piece. And then this is just to kind of wrap up, to make the point that we have a really great crisis system in Arizona, and we know that, and I'm very grateful for it. It didn't happen overnight. It was a 20-year evolution. I've been there for 9 of it. But it started, you got to start somewhere, and they started back in 2000 with the mental health court and the CIT training, and it's been growing from there. So so sometimes people look at this and well, gee, we don't have all of that, and it's well, that's why you start. And the fact that y'all are all here is already a really good start, because just getting people talking is that in and of itself can start to help things. And I encourage you to take a look at that roadmap report and maybe use some of the tools in there to start to drive some of the conversations about what do we have and how is it coordinated. And with that, I am happy to take questions. And I think y'all will get this PowerPoint, and there's links to a lot of the stuff in there, and then you can always email me if you have other questions. Yep.
Hi, we are kind of at the beginning of your timeline. We have some crisis services in place, but it depends on the county and the local community mental health center. One of the questions the question that I have, we are having a very difficult time with confidentiality as a barrier to those co-responder teams. Health departments and EMS and law enforcement are worried about contacting and providing demographic or personal information to our crisis folks. So how did you all get around that?
So you were in like a room full of lawyers, and some of them will tell you that HIPAA doesn't prevent a lot of stuff that people think it does prevent. Thanks. My brother's a healthcare attorney, so I have to channel him sometimes. But it's true. So first of all, the police are not a HIPAA-covered entity. So I'm doing good. I got my CLEs going. But so the police can tell the health people anything. And oftentimes, too, the police, they don't even, and so then everyone gets concerned, well, then, but we don't want to disclose, their diagnosis and their medications to law enforcement. Law enforcement doesn't want to know their diagnosis and their medications. So a lot of the stuff that then we think, that we worry about sharing with them is not really relevant. And so that's one big piece. Another, I mentioned trust. I often present with my police sergeant buddy, and he tells a story of how when they first started doing all of this with his mental health support team, they would call the case manager at the clinic and be like, "Hey, do you have so and so in your clinic? Because we've been out to their house and blah blah blah," and they'd be like, "I can neither confirm nor deny that I know that person." And now that and it took the police to be showing up at these different meetings and, their liaisons showing up and really being part of the community collaborative to build that trust. And so now when he calls and they go, "Hey, I have so-and-so," they're like, "Well, I can neither confirm nor deny that I know that person, but go on." So they can listen to this stuff. Also, for sharing, for the different service providers actually sharing, emergency rooms and mobile crisis teams in our facilities and stuff. Again, HIPAA says you can share stuff in an emergency, and you can share stuff for operations and treatment. And so that's what you're doing. And so that's not prohibited. It is, because of the way we're structured under kind of all the crisis has a single payer, essentially. And we're all kind of part of that. I think that also, there's data that gets sent, automatic. Oops, sorry. I talk with my hands, and then I got my monster here. But we do some data feeds and stuff so that the different parts of the system know who's going through crisis. And I think that's possible because we all have this single payer system. But that's. But you can also do things with MOUs. So, for example, the emergency room that's right next to us. We send patients back and forth all the time. And what a pain in the butt it was to have to call people and have them read labs off the screen to us on the phone. So we did an MOU, and now we have read-only access into their EHR and they do into ours. And so, all that takes is, a lawyer and some forms. And find that one who's telling you that HIPAA doesn't prevent anything. Yeah, you have to get their kind of heads together, and then sometimes it doesn't trickle down to the person who answers the phone in the middle of the night. But then you can give that feedback back. And other questions?
Yes, ma'am. This is very impressive, and thank you all. Thank you for sharing. 2 questions. With your research and some of the many great things you're doing, is there any component for the veterans in Arizona? Do you have anything specifically for that? And also, as far as the community involvement, are there any connections to faith-based organizations and some of your connections in the great system that you have?
Yeah, so the crisis system, for what I was describing, serves everyone in the whole community, including veterans. That said, there's kind of in communities, there's sort of these islands, right? And the VA is kind of one island, Universities is kind of like another island, where, and so the people who are the coordinators for the crisis system for our regional behavioral health authority, because they oversee the mobile teams and stuff, not me, but they have made quite a bit of effort to reach into those islands. And there's also military base, like we have a big military base too in Tucson. And they have MOUs so that like when they have to go onto the base, there's all this crazy paperwork and whatever. Like now they have some faster way where they can get in there because they have an MOU. The same thing with, the VA has its VA hospital, but all that doesn't do like the involuntary stuff, and so that all goes through this other the mental health system I described. But then we collaborate closely with the VA because regardless of where the person is getting their care, we need to collaborate with that provider to make sure that there's a good plan for them coming out and that we have the information that we need when they're in crisis. And so, yeah, there's relationships with the VA and stuff there, and then same with universities. That the mobile crisis team can go on to the university campus, and we're actually working on right now like a way because like their clinic doesn't have a prescriber, just like psychologists, and so we're going to be able to get them over into our urgent care. So that's another example. As far as faith-based community goes, yeah, so we in our kind of crisis collaborative. There are like the advocacy organizations like NAMI and stuff are there, and there's some faith-based folks there, and then there's all kinds of faith-based housing programs and stuff that we work with too. So it's really like a whole community collaborative. And the tribal stuff, I didn't even talk about that, but we have like 22 tribal nations in Arizona, so that's another area where there's a lot of special attention on how to collaborate with those communities and have, like, whether it's MOUs and or liaisons and involving them in the various collaborative stuff.
Thank you so much for presenting this. I'm Lindsay Jasinski, and I'm from UK Healthcare, and we're actually working with Dr. Zeller. So I'm super excited to hear about all this on developing an empath center. My question is, we're still building out our system of crisis services, and how do you recommend that we use empath to help fill some of those gaps that we don't currently have, like living rooms or other sobering facilities, things like that? Can empath serve that function while we build that system of care, and do you have recommendations for how to do that?
Yeah, so we have, in our facility, we take anyone, so that includes high acuity all the way down to the lower acuity. And people who really need the lower acuity, may not like being in the higher acuity area. That's one reason why we've over the years built out our urgent care, where people don't actually need that overnight component so much as just to get really good care coordination and be connected to what they need. So we really try to figure out from the very beginning, where does this person, do they need to be, for safety reasons, need to be in the empath unit, which for those who don't know, what an empath unit is basically kind of like what I described with our crisis response center. Imagine kind of like a smaller one of those, but attached to an emergency department. So it's actually part of the ED or under the hospital license. And detox, I'm not sure how it is in Kentucky. Different states have all these weird rules sometimes around substance use and it has to be separate. And there were times in Arizona when it was well, technically, if all they need is substance use care, then they're supposed to go to the detox place. But how many people do all they need is substance use care, right? People are coming in and they've got mental health issues, they've got depression, they've got anxiety, and they need detox. And so our philosophy has always been, we treat everything, and if they need detox, we do that too, and as well as start Suboxone and things like that. So I think if you just have that philosophy of we're going to take all comers and then figure out what's the best place for them, whether that's staying in our facility or transferring them out, as things get built. The other thing too is we work really closely with our REBA and use crisis data to show where the gaps are. So you may be collecting data to show that, hey, there's a whole bunch of people here that you're paying, whoever your payer is. I'm not, sure who's going to be paying for all this, but like whoever, that's all I always think about too. When patients come through and like they're not getting the services they need, my brain always goes to who's responsible for that patient. Because I'm sure whoever's responsible for that patient doesn't like paying for things that don't work or could work better. And so if there's a group of people that are coming in that kind of having them in the empath unit's kind of overkill, and they could have done better in more like a crisis res or peer respite, collect data on that and say, it would probably save money if like somebody started up one of these. So I guess I answered all your questions.